Welcome back to the Deep Dive. Today we are taking on, well, one of the most vital and urgent fields in all of medicine, pediatric ophthalmic disorders. The stakes here are just astronomical. When we talk about a child's sight, especially during those critical developmental years, early intervention isn't just helpful.
No, it's everything.
It's the definitive barrier between a lifetime of sight and permanent, irreversible blindness.
That's absolutely right. And this isn't some leisurely academic exploration. This is applied, high-stakes knowledge.
No.
Our listener has given us this incredibly detailed stack of clinical sources.
Yeah, it's exhaustive.
It really is, covering everything from, basic screenings to intricate genetic diseases and malignant tumors. Our mission today is to move beyond just reciting facts.
Right.
We want to achieve a true mastery of this material, focusing on the clinical nuances and the time-sensitive protocols that define elite care in this field.
Okay, let's unpack this and immediately raise the intellectual tempo. We will be meticulously covering the non-negotiable goals of screening, identifying the specific high-risk factors that demand immediate action,
Yes.
decoding the pathology behind congenital anomalies, analyzing severe infections, including that terrifying threat of orbital cellulitis,
Very serious.
and finally, mapping how complex systemic diseases, show up in the eyes. Hashtag tag the core rationale for pediatric eye screening.
Okay, so the foundational principle here, it's rooted in critical developmental neurobiology and, frankly, communication failure.
Communication failure.
Simply put, an infant or a young toddler cannot communicate symptoms like blurry vision, pain, floaters, or double vision. They just can't.
They don't have the words or even the concept.
Exactly. They don't know what normal is, so they can't possibly tell you when something is wrong.
So if they can't tell us,
Yeah.
why is screening so absolutely vital in children? What's the ultimate goal here?
The primary goal is really twofold. First, obviously, to detect an existing eye or visual disorder.
Right.
And second, and this is perhaps more proactively important, to identify established risk factors before the disorder causes fixed permanent damage. The entire exercise, it's geared toward ensuring prompt referral for detailed evaluation and appropriate management. It's all about limiting ocular morbidity.
So we're fighting the clock.
We are fighting against the clock to prevent permanent, irreversible blindness.
And when we talk about that irreversible blindness, what exactly are we fighting against in terms of timing? Is there a specific window?
Oh, absolutely. We are fighting against the critical developmental window. You see, the human visual system isn't fully formed at birth.
Right.
It develops intensely during the first, say, 6 to 8 years of life. Now, if during this period the brain receives poor or conflicting visual information.
Like from a cataract or a misaligned eye.
Exactly. So from an opaque congenital cataract or a significantly misaligned eye, strabismus, then the neural pathways in the brain dedicated to processing that visual input just fail to develop properly. This failure, it's known as amblyopia or lazy eye.
Yeah.
And the devastating part is it can become permanent if it's missed early on.
Even if you fix the eye problem later.
Even if you perform perfect surgery later, the brain essentially learns to ignore the bad eye forever. That connection is lost.
That urgency you mentioned takes us directly to identifying those risks.
Yeah.
Our sources break down the criteria for immediate referral into 3 big categories. Let's start with category I, general health risks.
Okay.
Who automatically gets referred based on their systemic health?
Right. So category I links the eye directly to the infant's overall physical stress and any systemic conditions they might have. The most critical group here is high-risk infants,
Meaning premature babies.
particularly those born with extreme prematurity. The typical cutoff is a gestational age of less than or equal to 30 weeks, or sometimes a very low birth weight, like under 1,500 grams.
And why them specifically?
They are immediately at risk for retinopathy of prematurity, or ROP.
Okay, let's clarify ROP right now since we mentioned it. What exactly is that?
ROP is a disease specific to premature babies. Essentially, their retinal blood vessels, which are still developing at birth, grow abnormally or can even stop growing entirely.
And that's due to oxygen.
Often due to the fluctuating oxygen levels they encounter in the NICU after birth compared to the stable environment in the womb. If it gets severe, this abnormal growth can actually pull the retina away from the back of the eye.
Causing retinal detachment.
Retinal detachment and blindness, yes. These infants need mandatory, very structured screening schedules, no question.
Okay. Beyond prematurity, what other systemic conditions are major red flags for referral?
Well, pretty much any systemic inflammatory or metabolic condition, you have to think about things like juvenile rheumatoid arthritis, JRA.
Why JRA?
Because of its strong potential link to uveitis, inflammation inside the eye, also thyroid disease or diabetes mellitus, these syndromes often have well-known ocular links.
So the eye problem might show up first.
Sometimes decades before the systemic disease is fully rampant, yes. We also have to consider external factors. Things like suspected non-accidental trauma child abuse.
A grim reality.
It is. Or chronic use of certain high-risk medications. Long-term systemic steroids are a big one, or hydroxychloroquine, which can cause a specific retinal toxicity.
Right. Okay, that's category 1. Now, category 2, family history. This sounds like it provides the genetic smoking gun, potentially.
It often does. If a parent knows this history, it can dramatically shorten the diagnostic process. A known, strong family history absolutely demands referral.
For what conditions specifically?
Especially true for specific hereditary diseases like retinoblastoma, the eye cancer in children, or childhood cataract, childhood glaucoma.
Okay.
But it also extends to issues that might seem less immediately severe but are chronically problematic. Things like significant refractive errors, needing strong glasses early on, or retinal dystrophy or degeneration. And common conditions like strabismus, which is a squint, or amblyopia, the lazy eye we just discussed. These often run in families.
So that risk increases.
Dramatically. We also include complex blood disorders like sickle cell disease, which can cause serious vascular complications in the retina, and, of course, any history of non-traumatic childhood blindness in the family.
Got it. And finally, category 3. This covers the observable signs, what parents, pediatricians, or teachers might actually notice. These are those nonverbal clues we started with.
Exactly. These are the behavioral and physical signs that might signal distress or misalignment. Behaviorally, you look for things like defective fixation. The eyes aren't steady, they wobble or drift.
Okay.
Constant squinting is another sign. Or a tendency for the child to close one eye, especially in bright light.
Why would they do that?
It's often a sign the child is sort of self-patching, trying to avoid double vision that comes from a misalignment.
Makes sense.
We also look for movement abnormalities like nystagmus, that's involuntary rhythmic eye movements, or a consistent head tilt or turn.
Now, if a child has a consistent head tilt, isn't that sometimes just a habit? How do we know for sure that's ocular and not, say, orthopedic? What's the quick clinical differentiator there?
That's a really sharp question. A head tilt can be a way to compensate for an ocular muscle imbalance, specifically an incomitant strabismus or a nerve palsy affecting an eye muscle.
So they're tilting to see better.
Exactly. The child is subconsciously tilting their head to shift their gaze into the field where their eye muscles work best together, minimizing the double vision or strain.
So how do you tell it's not their neck?
The quick differentiator is pretty straightforward, actually. An ophthalmologist can test the child's ocular alignment in various head positions. If the eye misalignment resolves or improves significantly when the head is tilted in that specific habitual way,
Then it's the eyes.
then the tilt is almost certainly ocular in origin. An orthopedic neck issue just won't respond to that kind of simple ocular manipulation.
That distinction is definitely mastery-level knowledge. Okay, what about the physical signs parents might see?
Physical signs include any obviously abnormal appearance, eyes that seem too large, that's called boophthalmos, a classic sign of congenital glaucoma,
Right.
or eyes that look cloudy, suggesting a cataract or a corneal opacity, drooping eyelids, which is pupillosis, or any visible masses like swelling or lumps around the eyes.
And persistent symptoms.
Absolutely. Persistent discharge, persistent redness, or photophobia, significant light sensitivity must be taken seriously. They can signal chronic inflammation or infection.
And of course, the referral criteria also link visual deficits to functional problems like learning disabilities or dyslexia.
Yes, it's quite common that a primary visual issue, especially an uncorrected refractive error or maybe a subtle binocular vision problem, can mimic or significantly exacerbate learning difficulties.
Because vision is the main input.
The vision system is the primary input pathway for learning for most children. You have to rule out a vision problem first.
Okay, this brings us to a massive challenge. How on earth do we assess vision when the patient can't read, can't really talk reliably, or cooperate?
Right.
We can't just pull out a Snellen chart like with adults until the child is much older.
No, you can't. The examination is heavily modified by age, and honestly, it's quite dependent on the examiner's ingenuity and patience.
Right.
For infants, say less than 6 months old, the examination is almost pure observation, ideally in a comfortable, relaxed setting, often just sitting on the mother's lap.
So what are you looking for?
Visual acuity assessment is limited, really, to assessing fixation and following. Do the eyes fixate steadily on a light or an interesting target, and can they track it smoothly as it moves?
And when should that be solid?
We expect steady fixation and reasonably good alignment to be fully established and synchronized by around 4 to 6 weeks of age. Before that, some wandering is normal.
Okay, what tools do we use for the preverbal child, maybe 6 months to 3 years old?
We usually start with a gross assessment, observing if they can accurately follow colorful objects, maybe a small toy. And importantly, can they reach accurately for small targets, like a tiny bead or a piece of candy?
Testing hand-eye coordination.
Exactly. And to test for unilateral vision loss, which is a common early sign of developing amblyopia, we perform a resistance test.
How does that work?
We briefly occlude or cover one eye. If the child strongly resists or fusses when we cover the good eye, we can infer that the uncovered eye likely has poor vision.
Because you're blocking their only good view.
Precisely. The child is unhappy about having their only reliable visual input blocked. It's a simple but effective clue.
Now let's talk about those highly specialized objective tests mentioned in the sources. They sound like they provide solid data, even if the child is totally uncooperative.
They do, and they are critical for truly understanding the vision potential in this challenging age group. We often use electrophysiological tests that measure the brain's actual response to visual stimuli.
Like the pattern VER.
Pattern-induced visual evoked response, or pattern VER, yes. We show the child complex checkered or striped patterns on a screen. These patterns generate a tiny electrical signal in the visual cortex if the child can resolve them.
And you measure that signal?
We measure that signal using electrodes on the scalp. The smallest pattern that generates a reliable signal gives us an objective estimate of the child's resolution acuity.
Okay. And the optokinetic nystagmus, or OKN, how does that work?
OKN is a simpler but still objective reflex test. The child watches a moving striped drum or screen. If the child can actually see the stripes, their eyes will involuntarily jerk back and forth in a repetitive motion. That's the nystagmus, as they try to track the moving pattern. The width of the narrowest stripe that still elicits this nystagmus gives us another measure of their resolution acuity. These specialized techniques are really crucial because they don't rely on a behavioral response like pointing or talking, only a neurological one.
Got it. Now, as the child develops language and cognitive skills, the testing must transition.
Yes, absolutely. For preschoolers, say aged 3 to 5 years, we can move to non-literate symbol matching tests. This is a huge step up in terms of reliability.
What kind of symbols?
We often use GHAI symbols, which are simple, easily recognizable pictures like a house, an apple, a car, or the tumbling E test, where the child just points the direction the legs of the E are facing.
Up, down, left, right.
Exactly. Yeah. Or the HOTV card tests, which uses just those 4 letters. The goal is to get a reproducible, quantifiable measure of acuity without requiring actual letter recognition.
And finally, around age 5 and up, we can use conventional methods.
Exactly. By then, most children can cooperate with the familiar Snellen visual acuity chart, calibrated for 6 meters or about 20 feet. We can use alphabets or still rely on tumbling E or Landolt C symbols, the broken ring, if literacy is still a bit of a barrier.
Now, a full exam is obviously more than just acuity. What are the other non-negotiable elements?
Oh, absolutely. A full ophthalmic exam must include checking pupillary reactions, making sure the pupils constrict properly to light, which tells us the afferent nerve pathways are working.
Great.
And critically, a fundus examination. We have to visualize the back of the eye, the optic disc, and the macula. Initially, we try this using a direct ophthalmoscope, maybe through an undilated pupil.
But that view is often limited.
Often very limited, yes, especially in a wiggly child. So dilation is frequently required.
Okay. Why dilate?
For a detailed, comprehensive look at the entire retina, especially the periphery, dilation is mandatory. We use mydriatic drops, things like phenylephrine, tropicamide, or cyclopentolate, to widen the pupil.
And how do you view it then?
For the most efficient and widest field of view, the examiner uses an indirect ophthalmoscope worn on their head, along with a handheld lens. This allows for the detection of peripheral issues like retinopathy of prematurity, peripheral retinal holes, or Coates disease, which would be completely missed with just a direct scope.
And we noted this critical caveat earlier. Sometimes the patient simply cannot be assessed safely or accurately while awake.
That leads to the need for examination under anesthesia, or EUA. This is often required for infants, sometimes for patients with significant intellectual disability, or children with severe photophobia and blepharospasm, like those suspected of having congenital glaucoma or a dense corneal opacity.
So it's a procedure in itself.
It is. EUA allows the clinician to measure intraocular pressure accurately, perform a thorough slit lamp exam of the front of the eye, and examine the fundus in detail without the child fighting the process. It's considered a minor procedure, but it does require general anesthesia and, of course, parental informed consent. But often, it's the only way to get a definitive diagnosis and plan treatment in the very young or uncooperative child.
Okay, let's transition into the specific pathologies, starting with the timeline. We need to clearly differentiate between a disease that is congenital and one that is developmental. They sound similar.
They do, but the distinction is important. Congenital means the condition is manifest at birth. It's visible or detectable right away. Think of a total cataract that completely opacifies the lens from day one.
Or fused eyelids.
Or cryptophthalmos, exactly, where the eyelids are fused shut at birth. Developmental, however, describes a defect that was structurally present at birth that might not be detected until later.
Give me an example.
Like maybe a partial congenital cataract that doesn't significantly impact vision until the child is 6 months old and starts showing tracking issues. Or juvenile glaucoma, which is often due to a developmental anomaly in the eye's drainage structures, but the high pressure and symptoms might not manifest until later in childhood or even adolescence.
Got it. So focusing on the structures themselves, what are the major abnormalities of the globe, the eyeball itself?
We see issues primarily with size. Microphthalmos is an abnormally small eyeball. Nanophthalmos is an even smaller, structurally abnormal eye, often extremely farsighted.
And most extreme.
And ophthalmos is the complete absence of the eyeball. These conditions are usually severe and often linked to complex genetic syndromes or perhaps interuterine infections during pregnancy.
What about the lids and the adnexi, the surrounding structures? You mentioned cryptophthalmos, the fused eyelids.
Yes, cryptophthalmos is very severe, thankfully rare. More common are issues like lacrimal system obstructions. The nasolacrimal duct, the tear duct, gets blocked.
Leading to watery eye.
Persistent watering, yes, or even infection in the tear sac, which is dacry cystitis. For the eyelids themselves, we see structural issues like ptosis, the drooping eyelid, blepharophomosis, which is a complex syndrome involving ptosis, and a shortening of the horizontal width of the lids. Or lid coloboma, a notch or gap in the lid structure itself.
When do these lid issues become an immediate surgical urgency beyond just how they look?
They become urgent when they directly threaten the visual axis or the health of the cornea. If a severe ptosis or maybe a large lid coloboma completely covers the pupil,
It blocks the light.
it blocks the light, causing sensory deprivation and amblyopia. That requires immediate oculoplastic reconstruction to clear the visual axis. Similarly, if the lids cannot close properly, a condition called lagophthalmos, the cornea will dry out,
Leading to?
leading to exposure keratopathy, essentially severe dry eye damage, scarring, and potentially infection. That also needs urgent surgical correction.
And those systemic connections surface again here with vascular abnormalities around the eye.
Precisely. You might see capillary hemangiomas, those strawberry marks, or deeper cavernous hemangiomas, or even orbital varices, which are dilated veins. These often present as external swelling or a visible lesion.
You all have to check.
You must always consider if these are isolated findings or if they're part of a larger neurocutaneous syndrome, the phagmatoses like Sturge-Weber or neurofibromatosis, which we'll definitely need to cover in more detail later. #tag diseases of the conjunctiva and anterior segment.
Okay, let's move to the front structures of the eye now. Congenital corneal opacity. A cloudy cornea at birth is an emergency because it immediately blocks vision. To master the potential causes, we have that great mnemonic, stumped.
Yes, this mnemonic is absolutely indispensable for rapidly generating a differential diagnosis when you see an opaque cornea in an infant. Let's break down the pathology behind each letter because understanding the why is key.
Right. Start us off with S, T, and U.
Okay. S is for sclerocornea. This is a congenital anomaly where the normally transparent cornea tissue actually takes on the opaque white appearance of the sclera, the white part of the eye.
So it's fused looking.
It looks like the white part extends over the colored part, yes. T is for birth trauma. Specifically, injury from forceps during delivery can cause a tear in the deep layers of the cornea, Descemet's membrane,
Leading to swelling.
leading to acute corneal edema, or swelling, making it cloudy. U is for ulcer, usually an infectious ulcer secondary to an intrauterine infection, like herpes, or an infection acquired during birth.
Okay. M and P seem to detail storage disorders and structural failures.
Exactly. M stands for mucopolysaccharidosis. These are metabolic storage diseases where abnormal metabolic byproducts build up throughout the body, including the cornea, causing progressive clouding.
MP.
P is for Peter anomaly. This is a major developmental structural failure. It's a type of anterior segment dysgenesis where the iris and the cornea fail to separate properly during development. They can be fused, and sometimes the lens even touches the back of the cornea,
Causing a central opacity.
causing a severe, often central corneal opacity. It's complex.
Got it. And E and D finish the list.
E is primarily for endothelial dystrophy, like congenital hereditary endothelial dystrophy, CHED. But critically, it also stands for endothelial dysfunction secondary to congenital glaucoma.
How does glaucoma cause cloudiness?
The high intraocular pressure in congenital glaucoma damages the endothelial cells in the back of the cornea, which normally pump fluid out. When they fail, the cornea swells with fluid edema and becomes cloudy.
Okay, and D.
D is for dermoid. This is a type of choristoma normal tissue in an abnormal location. It's a benign, often yellowish, tumor-like growth, typically located at the limbus, the junction of the cornea and sclera. If it's large, it can physically block the line of sight or cause significant astigmatism.
That is extremely helpful. Really unpacking the why behind each letter of STUMPED. What other anterior segment developmental defects do we encounter?
Well, you can see things like cornea plana, an abnormally flat cornea which causes high hyperopia, more severe forms of anterior segment dysgenesis, which is a spectrum of developmental problems, and iris issues like aniridia.
Which is absence of the iris.
Yes, partial or complete absence of the iris. It's often linked to Wagner syndrome, which includes Wilms tumor, so that requires systemic workup, or iris coloboma, that keyhole-shaped defect in the iris, which can sometimes extend back to involve the retina and optic nerve.
And the lens itself. We touched on cataracts, but you mentioned PHPV earlier. Persistent hyperplastic primary vitreous? What exactly is that condition?
Okay, so the primary vitreous is a temporary vascular network that nourishes the developing lens inside the eye during gestation. Normally, this entire network completely regresses before birth.
But in PHPV?
In PHPV, it fails to regress fully. It persists, often forming a fibrous stalk that attaches to the back surface of the lens.
And that causes problems?
Oh, yes. This stalk can contract, pulling on the lens and surrounding structures. It often causes a cataract, can lead to retinal detachment if it pulls on the retina, and is frequently associated with microphthalmos, a small eye.
Is the stalk vascular?
Often it is, yes. The persistent vessels can bleed, leading to vitreous hemorrhage. So PHPV is a severe condition, often presenting with leukocoria, that white pupil reflex, mimicking retinoblastoma. It requires careful evaluation, often with ultrasound.
We transition now to acquired conditions, things that happen after birth.
Yeah.
Let's start with one that is a true ocular disaster. Vitamin A deficiency leading to keratomalacia. It really shows how systemic failure can manifest as rapid, blinding ocular destruction.
It really does. This is perhaps the single most important preventable cause of pediatric blindness globally, especially in developing nations.
Right.
Now, while an infant under 6 months usually has adequate hepatic vitamin A reserves stored up from the mother, severe deficiency is frequently precipitated later by a combination of poor feeding practices and an acute systemic infection.
What kind of infections?
Measles is a classic trigger. Also, pneumonia or severe acute gastroenteritis. These conditions dramatically deplete the body's already low vitamin A stores very rapidly.
So what are the stages of this catastrophe? How does it progress in the eye?
The milder stages start subtly. Xerosis, that's dryness, and a sort of keratinization, a roughening of the conjunctiva, the white part's surface, and nyctalopia, difficulty seeing in dim light or night blindness.
Okay.
Then you might see Batas spots, these characteristic foamy, triangular-looking keratin deposits that appear on the conjunctiva, usually near the edge of the cornea.
And the crisis point?
The crisis point is keratomalacia. The cornea itself literally softens, liquefies, and melts away. It can perforate, leading to loss of the eye, and it's often bilateral. Utterly devastating.
The treatment protocol is incredibly precise and urgent. Could you walk us through those specific high doses of vitamin A again? We know timing here is everything, and getting the dosing wrong has major consequences.
Absolutely critical. We must administer high-dose oral vitamin A immediately. The standard dose for children over 1 year is 200,000 international units, IU stat, meaning right away.
Okay.
This dose is repeated at 24 hours and then again usually after 2 weeks. This rapid, massive dosing is required to quickly replenish the systemic reserves and hopefully halt the corneal melting process before it's too late.
And you mentioned that critical dosing modification for smaller children, half the dose. Why exactly is that necessary, and what's the specific risk we are trying to avoid?
Right. For children less than 1 year old or those weighing under 10 kilograms, we absolutely must use half the dose, so 100,000 IU.
Why the reduction?
The risk we are avoiding is acute vitamin A toxicity. In infants, this can manifest as induced intracranial hypertension, also known as pseudotumor cerebri.
So high pressure in the head.
Yes, a rapid, dangerous increase in pressure inside the skull. It can cause severe headaches, vomiting, bulging fontanelle, and can easily mimic a brain tumor or meningitis. It's a serious complication.
And if the child is vomiting?
If the child is vomiting severely and can't keep the oral dose down, we use a single intramuscular injection of vitamin A to ensure immediate absorption. This precision in dosing and route is a non-negotiable step in mastering this condition.
Let's discuss infections next. When a child presents with a red, swollen eyelid, the immediate clinical question has to be, is this just perceptal cellulitis, or is it the far more dangerous orbital cellulitis?
That distinction is potentially life-saving. Perceptal cellulitis is an infection confined to the tissues in front of the orbital septum, essentially, the skin and superficial tissues of the eyelid.
Okay.
Orbital cellulitis is much deeper. It involves the tissues behind the orbital septum, within the organ itself, the eye socket.
And why is that location so dangerous?
The orbital cavity is located smack in the middle of the anatomical dangerous area of the face. This is because its venous drainage system, the veins carrying blood away, is closely connected via valveless veins to the cavernous sinus at the base of the brain.
Meaning infection can spread easily.
Infection can spread backwards directly into the brain. If orbital cellulitis goes untreated or is undertreated, it can lead to meningitis, brain abscess, or even more dangerously, cavernous sinus thrombosis,
Which is?
a blood clot forming in that critical cavernous sinus. It has an extremely high mortality rate even today. So if orbital cellulitis is suspected, it is an absolute surgical and medical emergency requiring hospitalization and IV antibiotics.
How do you confirm the diagnosis and look for a potential abscess back there?
Clinically, orbital cellulitis often presents with more severe signs. Pain with eye movement, maybe reduced vision, sometimes proptosis, bulging eye. While CT or MRI is often used, especially if intracranial spread is suspected, ultrasonography, specifically B-scan ultrasound of the orbit, is often used initially and is very effective at detecting an orbital abscess, a collection of pus.
And if there's an abscess?
If an abscess is present, systemic and topical antibiotics alone are usually insufficient. The abscess must be drained surgically, often urgently, by an ophthalmologist or an ENT surgeon if it originates in the sinuses. This provides source control and prevents further spread into those critical surrounding structures.
Okay. Moving to the surface infections, let's quickly revisit ophthalmia neonatorum, that's conjunctivitis in the first month of life.
Yes.
The absolute urgency here, as mentioned in the sources, is to rule out Neisseria gonorrhea. Why?
Correct. Gonococcal conjunctivitis in a newborn is hyperacute. It causes massive amounts of pus, severe swelling, and it can rapidly penetrate the intact cornea, leading to corneal perforation and blindness within days if not treated aggressively.
Wow.
So immediate conjunctival smears for gram stain and culture and urgent targeted systemic and topical antibiotic treatment based on sensitivities are mandatory. It's a true ocular emergency.
Now let's focus on the most severe ocular surface infection, keratitis, which is a corneal ulcer. Trauma, especially involving vegetative matter, seems to be a major predisposing factor in children.
Yes, it is. Trauma is probably the most common cause in kids, particularly injury involving organic material like getting poked with a wooden stick, a branch, or a thorn.
Why is that type of trauma worse?
Because it directly introduces fungal elements into the cornea, significantly increasing the risk of a fungal keratitis, which is notoriously difficult to treat. Other risks include poor hygiene, maybe chronic inflammation from allergies, or, ironically, the misuse of topical steroids.
How do steroids make it worse?
Topical steroids suppress the local immune response in the cornea. This allows minor infections, which the body might normally clear, to become major sight-threatening ulcers. They basically open the door for bacteria, fungi, or viruses.
Since this infection can literally destroy the cornea in days, what is that aggressive initial treatment protocol for a suspected bacterial ulcer? The sources mention hourly fortified drops. That sounds incredibly intensive.
It is incredibly intensive and necessarily so. We are essentially shock treating the infection to save the cornea. It usually requires an examination under anesthesia, EUA, for proper assessment and critically immediate corneal scraping.
To get samples?
Yes, to collect samples from microbiology, gram stain, cultures for bacteria, fungi, maybe even acanthamoeba, but we can't wait for the results.
No.
While we wait, empirical therapy must begin immediately. This usually involves freshly prepared, fortified topical antibiotics. These are much higher concentrations than standard drops.
Like which ones?
A common combination is fortified 5% cefazolin and fortified 1.3% tobramycin, or similar broad-spectrum coverage. And the key is the frequency.
Hourly.
These must be administered hourly, often alternated every half hour around the clock for at least the first 48 hours. This aggressive schedule is absolutely necessary to achieve the highest possible antibiotic concentration in the corneal tissue to try and kill the bacteria before permanent scarring and perforation occur.
Wow, round the clock. That's intense. And if it turns out to be fungal or viral based on the scraping or culture?
If it's concerned or highly suspected to be fungal keratitis, the treatment shifts usually to hourly topical natamycin 5%, which is an antifungal. Viral keratitis, typically herpes simplex virus, HSV, requires topical antiviral therapy like a cyclover 3% ointment, usually 5 times a day for surface epithelial involvement. However, if the inflammation is deeper, involving the corneal stroma or the uvea, what we call keratuveitis, then systemic oral acyclovir is often mandated as well to manage the underlying viral replication and inflammation. Hashtags, #, allergic and inflammatory diseases.
Okay, let's shift to allergic reactions. These seem pretty common in kids, but the most severe type mentioned is vernal keratoconjunctivitis, or VKC. What makes VKC particularly dangerous compared to regular hay fever eyes?
VKC is a much more chronic, severe, and potentially sight-threatening form of allergic eye disease. It typically affects children and young adults, often in warmer climates. It involves not just the conjunctiva, but frequently the cornea as well.
What are the symptoms?
It presents with intense, debilitating itching, severe photophobia, light sensitivity, tearing, and a characteristic thick, ropey mucus discharge. You might also see giant papillae like cobblestones under the upper eyelid.
And the corneal involvement.
That's the real danger. The chronic inflammation and mechanical rubbing from those giant papillae can lead to corneal complications like superficial keratitis, shield ulcers, sterile ulcers on the cornea, and even permanent scarring, which can significantly impair vision.
Now, the management caveat surrounding topical steroids is absolutely critical here, perhaps more than anywhere else.
Yeah.
What is the mechanism of the danger with steroids and VKC?
Right. Topical corticosteroids offer very quick, often dramatic relief for the severe symptoms of VKC. However, they must be used with extreme caution for the shortest possible duration and only under strict ophthalmologist supervision.
Why such caution?
Because chronic, unsupervised use, which unfortunately happens if prescriptions are refilled without checks, is a major cause of serious complications. The biggest risks are secondary glaucoma, steroid-induced glaucoma.
How does that happen?
The steroid molecules, over time, can clog the eye's natural drainage system, the trabecular meshwork. This causes the intraocular pressure to rise, often silently at first, eventually damaging the optic nerve irreversibly.
And the other risk?
The other major risk is secondary infection. Steroids suppress the immune system, making the eye much more vulnerable to opportunistic infections, especially fungal keratitis or reactivation of herpes simplex virus, turning a severe allergy into a potentially blinding infection. So we try to rely on safer long-term options like mast cell stabilizers and topical antihistamines first.
Got it. What about uveitis? That's inflammation of the middle layer of the eye, the uveal tract.
Uveitis in children is complex because it can be idiopathic, meaning we don't find a specific cause, or it can be linked to underlying systemic diseases.
Like GRA again?
Like juvenile chronic arthritis, JCA or JAA. Yes, also psoriasis, sarcoidosis, or infections like toxoplasmosis. The presentation varies. Acute anterior uveitis, uveitis, is typically symptomatic red eye, painful, blurred, or dim vision, photophobia.
But chronic is different.
Chronic uveitis, especially the type associated with GHAI, is often deceptive. It can be almost completely asymptomatic. The eye might look white and quiet.
So how is it picked up?
Often it's picked up only on routine screening exams in children with GHAI, or sometimes vision loss occurs quietly over time due to complications like cataract formation, a complicated cataract, or swelling in the macula, cystoid macular edema.
And inflammation further back.
Intermediate uveitis, affecting the vitreous humor, or posterior uveitis, affecting the retina or choroid, is also often painless. It typically presents with floaters. The child might complain of spots or webs floating in vision, caused by inflammatory cells in the vitreous and decreased vision due to the haziness or retinal swelling.
Now this raises an important point. Malignancy can sometimes mimic uveitis. When should a clinician suspect an intraocular tumor instead of just inflammation?
That's a crucial differential. Certain malignant disorders, particularly retinoblastoma, but also things like juvenile xanth granuloma or systemic leukemias, can shed malignant cells into the anterior chamber or vitreous cavity.
And these cells look like?
These malignant cells can look exactly like the inflammatory cells of an acute or chronic uveitis. So if an apparent uveitis is unilateral, very persistent, maybe doesn't respond as expected to typical anti-inflammatory therapy, or presents atypically.
Red flag.
Big red flag. The clinician must perform a very detailed slit lamp and ophthalmoscopy exam, specifically looking for signs suggestive of a tumor, like an underlying mass, abnormal iris vascularity, or maybe pseudohypopyon, a layer of cells in the anterior chamber that looks like pus but is actually tumor cells. Ultrasound or further imaging might be needed. You cannot miss a masquerade syndrome.
And finally in this section, optic neuritis. What are the key features?
Optic neuritis is inflammation of the optic nerve. It typically causes a rapid, usually monocular one-eyed drop in vision. Critically, it's almost always associated with a relative afferent pupillary defect, or RAPD.
Explain RAPD quickly.
Normally, shining a light in one eye causes both pupils to constrict equally. With an RAPD, when you swing the light from the good eye to the affected eye's pupil paradoxically dilates slightly instead of constricting further because the damaged optic nerve isn't sending a strong enough signal back to the brain.
How does the optic nerve look?
It can vary. Sometimes the optic disc at the back of the eye looks obviously swollen. That's called papillitis. Other times, the inflammation is further back along the nerve, behind the eyeball retrobulbar neuritis, and the fundus initially looks completely normal.
But the vision is still down.
The vision is still down, and the RAPD is present. Any suspected optic neuritis requires immediate neuro-ophthalmology consultation to investigate potential underlying neurological causes, most importantly, multiple sclerosis, especially in adolescents.
Okay, section 4. The eye truly provides this unparalleled window into the body's systemic and metabolic state. Let's focus first on those connective tissue disorders that specifically affect the lens structure, causing it to displace.
Right. We need to contrast two classic inherited metabolic conditions that cause ectopia lentis, which just means a displaced or subluxated lens. First, homocystinuria.
What is that?
It's an inherited disorder of methionine metabolism. Systemically, it causes various issues, but ocularly, the key finding is typically a downward subluxation or dislocation of the lens.
Downward, okay. And why is surgical lens removal in a patient with homocystinuria considered so complicated? What is that unique systemic risk mentioned?
These patients have significant vascular fragility and are also prone to developing secondary glaucoma. But the most serious life-threatening risk during surgery, especially under general anesthesia, is thromboembolism.
Blood clots.
Yes, they have a greatly increased tendency to form blood clots in their arteries and veins. An ophthalmologist absolutely must coordinate closely with an anesthesiologist and often a hematologist before any procedure. Specific precautions, sometimes involving dietary management or medications like aspirin or heparin, are required to minimize this clot risk. It's high-stakes coordination.
Okay, now contrast homocystinuria with Marfan syndrome.
Marfan syndrome is a different connective tissue disorder affecting the fibrillin-1 gene. It also causes lens subluxation, but classically in Marfan's, the lens displaces upward and outward, up and out.
So the direction is key.
The direction of subluxation is a key differentiator. Ehlers-Danlos syndrome, another group of connective tissue disorders, can also affect ocular structures, causing lens subluxation or corneal thinning.
What about those really striking visual signs of deposition diseases? Things accumulating where they shouldn't.
Right. Deposition or storage diseases cause abnormal materials to build up in various tissues, including the eye, often in the retina or cornea. The classic cherry red spot at the macula is a hallmark sign.
What causes that appearance?
It's typically seen in lipid storage disorders like Tay-Sachs disease, Niemann-Pick, or other types of gangliosidosis. The nerve cells in the retina surrounding the macula become swollen and opaque due to the abnormal lipid deposition. This makes the underlying, normally reddish, central fovea stand out in stark contrast, hence the cherry red appearance.
And corneal clotting.
Corneal clouding, which we mentioned earlier with the stumped mnemonic under M for mucopolysaccharidosis, is seen in several types of MPS syndromes, and the Kaiser-Fleischer ring.
Ah, yes, the copper ring.
That distinct brownish-green ring seen on the peripheral cornea is pathognomonic, meaning it's uniquely characteristic for Wilson disease, which is a disorder of copper metabolism. ## musculoskeletal, neurodegenerative, and phacomatosis.
What's really fascinating here is how diseases that fundamentally affect muscle or nerve tissue throughout the body also manifest so clearly in vision and eye movements.
It underscores how interconnected everything is. Look at certain muscular dystrophies. For example, chronic progressive external ophthalmoplegia, CPEO, is characterized by psicosis, the droopy eyelids, and a severe progressive restriction of eye movements in all directions. Duchenne muscular dystrophy, while primarily affecting skeletal muscle, is also linked to cataract formation. And various neurodegenerative diseases, like the leukodystrophies, which affect the white matter of the brain, can result in extraocular muscle weakness, nystagmus, and often profound optic neuropathy leading to vision loss.
And the phacomatosis, those neurocutaneous syndromes, are absolutely crucial because they offer these visible systemic markers for often serious ocular disease.
They really do. These syndromes characteristically connect abnormalities of the skin, the nervous system, and the eye. Neurofibromatosis type 1, NF1, is the classic example.
What do you look for?
Systemically, you look for multiple café au lait spots on the skin, axillary freckling, and neurofibromas. In the eye, the key findings are Lisch nodules, these small pigmented bumps or hamartomas on the surface of the iris. NF1 can also be associated with optic nerve gliomas.
And Sturge-Weber.
Sturge-Weber syndrome is characterized by that distinctive facial port wine stain, a capillary malformation, typically in the distribution of the trigeminal nerve. If the stain involves the eyelids, especially the upper lid.
Risk of glaucoma.
There's a very strong association with the development of secondary glaucoma, often difficult to manage, likely due to abnormal vascularization in the eye's drainage angle on the same side. Nevus of Ota is another condition with skin pigmentation linked to glaucoma risk. #tag tumors and neoplastic diseases.
Tumors in children are thankfully rare compared to adults, but they necessitate rapid, urgent recognition and management. The single most critical malignant tumor in pediatric ophthalmology, as highlighted, is retinoblastoma.
Retinoblastoma is, without question, the most common primary intraocular malignant tumor of childhood. It arises from the primitive neuroectodermal cells of the developing retina. It is the definition of a blinding and life-threatening ocular emergency.
What is the classic observable sign that usually leads to suspicion, often first noticed by parents?
The primary presenting sign in the majority of cases is leukocoria, which means white pupil. Parents often notice it as an abnormal white or yellowish reflex in the pupil, maybe in flash photographs where one eye has the normal red reflex and the other looks white or cat's eye.
Now, it is absolutely crucial for mastery, as the source emphasizes, to distinguish retinoblastoma leukocoria from other causes, like a common congenital cataract. What's the key clinical differentiator?
Okay, this is vital. Leukocoria from a cataract is typically anterior. The opacity is right there in the lens, just behind the iris. Leukocoria from retinoblastoma is posterior. The white appearance is caused by the actual tumor mass sitting behind the lens on the retina.
Does it look different?
Often, yes. The tumor mass frequently has a somewhat yellowish, pinkish tinge due to its internal vascularization, and critically, retinoblastoma often contains areas of calcification.
And you detect that how?
That calcification is definitive on ocular ultrasonography, B-scan. Ultrasound is absolutely key in confirming the diagnosis and differentiating it from simulating lesions like PHPV or Coates disease. Rapid detection and referral to a specialized center are vital because while the survival rate is very high if the tumor is confined to the globe.
But if it spreads?
If it spreads outside the eye, particularly intracranially via the optic nerve, the prognosis plummets dramatically. Time is brain and time is life.
What about other tumors that can occur in the orbit around the eye?
Other primary orbital tumors in children include rhabdomyosarcoma, which is a fast-growing aggressive malignant tumor of skeletal muscle origin. Also, Langerhans cell histiocytosis can present as an orbital lesion.
And metastatic disease.
Yes, we must always remember metastatic lesions. Certain systemic childhood cancers can spread to the orbit or even inside the eye. Neuroblastoma is a common one. Also, Ewing sarcoma, and unfortunately, systemic leukemias and lymphomas can all infiltrate the orbit or the uveal tract, sometimes presenting initially as orbital swelling or even mimicking chronic inflammation like uveitis.
Okay, we shift gears now to the disorders that most frequently require primary care or general ophthalmology intervention and ongoing management, specifically refractive errors, amblyopia, cataract, and glaucoma in children. #tag refractive errors and ametropia.
Right. Refractive error, or emmetropia, simply means the eye isn't focusing light correctly onto the retina. Myopia, nearsightedness, hypermetropia, farsightedness, and astigmatism.
And since young children often can't report blurriness clearly.
Exactly. We have to watch carefully for those indirect signs. Frequent eye rubbing, habitual squinting, maybe sitting excessively close to the television, or holding books or toys very close to their face.
Now, how do you accurately measure the required spectacle prescription in a child? Adults just read letters on a chart, but children have that strong focusing ability, accommodation, which can really skew the results, right?
That's absolutely correct, and it's why cycloplegic refraction is essential for children. A child's focusing muscle, the ciliary muscle, is incredibly strong, especially in kids who are hyperopic, farsighted.
So they can compensate.
They can unconsciously accommodate or focus to overcome their farsightedness, making them appear less hyperopic than they truly are during a standard dry refraction. This can mask the true degree of refractive error.
So the drops paralyze that muscle.
Cycloplegic eye drops, like cyclopentolate or atropine, temporarily paralyze the ciliary muscle. This forces the eye to relax completely, revealing its true, static refractive power. Only then can we get an objective, accurate measurement of their myopia, hypermetropia, or astigmatism using retinoscopy or an autorefractor.
Okay. Now, once a child is corrected with the proper spectacles, if their vision still fails to improve to the expected level for their age, what's the next diagnostic step?
Failure to improve vision adequately, even after providing the best possible refractive correction, is a major red flag. It strongly suggests there's an underlying, perhaps subtle, organic pathology that the child's visual cortex simply cannot overcome, or that amblyopia has already set in.
So you investigate further.
Absolutely. We then have to investigate more deeply for conditions like maybe a mild retinal degeneration, something like Leber congenital amaurosis, which causes severe vision loss from infancy, or perhaps even a subtle microstrabismus, a misalignment too small to easily see but large enough to disrupt binocular vision. #tag strabismus and amblyopia, the lazy eye.
This next area, strabismus and amblyopia, is arguably one of the most critical issues to identify and treat aggressively within that developmental window we discussed. Define strabismus clearly for us again, the motor and sensory misalignment.
Okay. Strabismus is fundamentally the condition where the two visual axes, the lines of sight from each eye, do not simultaneously meet at the point the person is trying to look at. The eyes are pointed in different directions.
Types.
The main types are esotropia, where an eye deviates inward toward the nose, and exotropia, where an eye deviates outward toward the ear. There are also vertical deviations, hypertropia and hypertropia.
And how is it classified?
A key classification is concomitant versus incomitant. Concomitant strabismus means the angle of deviation, how much the eye turns, is roughly the same regardless of which direction the patient looks.
Okay.
Incomitant, or paralytic, strabismus means the deviation angle varies depending on the direction of gaze. This usually implies a problem with one or more specific eye muscles, perhaps due to nerve paralysis, or a restrictive condition like Duane syndrome or Brown's syndrome.
Now, the terrifying consequence of untreated strabismus, especially in early childhood, is amblyopia. How does the brain actively cause this functional vision loss? It's not just passive disuse, right?
No, it's an active process. The developing visual cortex, you can think of it like a complex computer, needs clean, clear, and identical input from both eyes simultaneously to wire itself correctly for high-level binocular vision and stereopsis 3D depth perception.
But in strabismus?
In strabismus, the input is conflicting. The brain receives two different images, leading to confusion or, more commonly, double vision, diplopia. The young child's brain brilliantly solves this immediate problem by actively suppressing or ignoring the image coming from the deviating eye.
Which works short term.
It eliminates the diplopia immediately, which is effective. However, this constant suppression prevents the normal development of the neural pathways connecting that suppressed eye to the visual cortex. Over time, this leads to a functional loss of visual acuity amblyopia. The eye itself might be healthy, but the brain can't process its input properly.
Master the definition of amblyopia for us again, just to be crystal clear.
Amblyopia is defined as subnormal visual acuity, typically 2 Snellen lines or more worse than the fellow eye, or below the age-expected norm for which no detectable anatomical or structural cause can be found during the ophthalmic examination. The eye looks healthy, the media are clear, the fundus is normal. It is a purely functional deficit of the developing visual system due to abnormal visual experience.
What are the two major categories of causes for amblyopia? And remind us again about that absolute critical treatment period.
The two main causes are, 1, sensory deprivation. This happens when something physically blocks clear visual input, like a dense congenital cataract, a severe ptosis covering the pupil, or even a significant corneal opacity.
Okay, and the second?
Second, abnormal binocular interaction. This is caused either by strabismus, as we discussed, or by significant anisometropia.
Define anisometropia again.
Anisometropia means there's a large, usually uncorrected difference in the refractive power, the glasses prescription, between the two eyes.
And the critical period.
The absolute critical treatment period, where intervention is most effective and reversal is most likely, is generally considered to be the first 6 years of life. After about age 7 or 8, neuroplasticity drops off sharply, and amblyopia risks becoming largely irreversible and permanent.
Anisometropia is often silent but can be incredibly damaging. How does just having a different prescription in each eye cause functional blindness in one?
It's insidious. If one eye is, say, highly farsighted or has severe astigmatism, and the other eye is near normal or only mildly affected, the brain receives a consistently clear image from the good eye and a constantly blurry image from the other eye.
So the brain chooses.
The brain naturally favors the clear dominant image and learns to suppress the persistently blurry one to avoid visual confusion. This leads to anisometropic amblyopia in the blurrier eye, often without any obvious eye turn or squint. It can easily be missed without proper vision screening and cycloplegic refraction.
So treatment focuses on forcing the brain to use the suppressed eye. Tell us about patching therapy, the classic treatment.
Patching therapy remains the gold standard for treating amblyopia. The principle is simple. We occlude or cover the good dominant eye, usually with an adhesive eye patch, for a prescribed number of hours each day.
Forcing the lazy eye to work.
Exactly. This forces the brain to pay attention to the input from the suppressed amblyopic eye, stimulating those underdeveloped neural pathways to mature and catch up. The duration and intensity of patching depend heavily on the severity of the amblyopia and, crucially, the child's age. Younger kids often respond faster.
Is patching the only step?
No, critically, we must first correct any significant refractive error with glasses or contact lenses. And patching is often done before considering strabismus surgery if needed. The goal is to achieve the best possible vision in the amblyopic eye first, and only then is surgery performed to restore cosmetic and potentially functional alignment of the eyes. #cataract.
Okay, let's talk about cataract in children. We know it affects adults, but in kids, as you've said, it's a frantic race against time due to amblyopia. What classification like congenital versus developmental determines the urgency?
The urgency is dictated almost entirely by whether the cataract is visually significant and when it appeared. Congenital cataracts that are present at birth and are visually significant, meaning they are dense or central enough to significantly obstruct the view of the fundus or demonstrably impair visual behavior.
Those are emergencies.
Those are absolute ophthalmic emergencies. Because of the profound risk of causing deep, irreversible sensory deprivation amblyopia, surgical treatment must be performed as soon as feasibly possible after birth. Optimally within the first few weeks of life for unilateral cases, maybe slightly longer for bilateral, to have any realistic hope of achieving good functional visual development. Developmental cataracts appearing later might have slightly less urgency, but still need timely intervention if visually significant.
This leads directly to the dilemma of optical rehabilitation after surgery. The sources clearly state that implanting an intraocular lens, IOL, is generally avoided for children under, say, 2 years of age. Why is that?
There are two major complex reasons for this reluctance to implant IOLs in very young infants. First, and perhaps most importantly, is the issue of rapid, explosive growth of the eyeball itself.
It grows a lot in the first couple of years.
A huge amount. The majority of the eye's axial length growth, The front to back length, which determines focusing power, occurs in the first 2 years of life. This makes predicting the correct IOL power needed for good vision when the eye stops growing, emetropia, virtually impossible.
So you'd end up with a huge prescription error later.
Exactly. You'd likely induce a massive refractive error, usually high myopia later in life, which is difficult to manage.
What is the second major reason to avoid early IOLs?
The second reason is the significantly higher risk of severe postoperative complications in infant eyes. Infants have a much more vigorous inflammatory response to surgery compared to adults,
Leading to problems like
leading to increased risks of developing secondary glaucoma, chronic inflammation, uveitis, and extensive fibrosis or opacification of the posterior capsule behind the IOL, which then requires further surgery.
So what's the alternative for vision correction?
Therefore, temporary optical rehabilitation is usually preferred for infants after cataract surgery. This typically involves using either special high-powered spectacles or, more commonly, pediatric contact lenses to correct the aphakic state, the lack of a lens. This is often supplemented with aggressive patching therapy for unilateral cases to combat amblyopia.
And they leave room for a lens later.
Often, yes. Surgeons might try to preserve a portion of the lens capsule rim during the initial surgery, creating a capsular bag or leaving it in the bag to allow for a potentially safer secondary IOL implantation when the child is older, maybe over age 2, and the eye growth has stabilized somewhat. #tag glaucoma, primary congenital, and developmental juvenile.
Let's tackle glaucoma in children. It's often a very different entity than adult glaucoma, frequently a structural problem linked to specific genetic mutations, like the CYP1B1 or MYOC genes mentioned. What is that classic presentation triad of symptoms that must trigger immediate investigation for primary congenital glaucoma?
Right. Primary congenital glaucoma, PCG, which typically presents within the first year of life, is classically characterized by a triad of symptoms: photophobia, severe light sensitivity; blepharospasm, forceful, involuntary squeezing shut of the eyelids; and epiphora, excessive tearing or watering.
Okay.
But the most striking sign, often noticed by parents or pediatricians, is baphomos, literally ox eye, meaning an abnormally enlarged eyeball and cornea.
Why does the eye enlarge in kids but not adults with glaucoma?
This occurs because the infant eye's sclera and cornea are still relatively soft and distensible compared to an adult's. The high intraocular pressure, IOP, literally stretches the outer coats of the eye, causing it to enlarge. This is very different from adult primary open-angle glaucoma, where the eyeball is rigid and the high pressure primarily damages the optic nerve head, causing cupping without enlarging the globe itself.
Diagnosis often requires that examination under anesthesia, UA again. Once PCG is diagnosed, what is the primary management approach? Is it drops like in adults?
Medical therapy eye drops like beta blockers or carbonic anhydrase inhibitors, and sometimes systemic agents can be used temporarily to lower the IOP. However, they are rare if the cornea is significantly cloudy due to edema from very high pressure, which is common. The surgeon simply cannot see the angle structures well enough to perform goniotomy safely. In these cases, an external approach is necessary. Procedures like trabeculectomy or trabeculotomy are performed.
How do those work?
Trabeculotomy involves finding the eye's main drainage canal, Schlemm's canal, from the outside and threading a probe to break through the inner wall into the anterior chamber. Trabeculectomy creates an entirely new artificial drainage channel, or bleb, under the conjunctiva for the aqueous humor to filter out of the eye.
Now, if the pressure is successfully lowered by surgery, but the cornea remains cloudy due to scarring from the previous edema, what's the final critical step needed to actually restore vision?
That's a crucial point. Controlling the IOP is only half the battle for vision. If the cornea remains significantly opaque even after the pressure is normalized, then corneal transplantation, keratoplasty, will be necessary to restore a clear visual axis.
Otherwise, amblyopia again.
Otherwise, even with normal pressure, the child will still develop profound and irreversible sensory deprivation amblyopia because no clear image is reaching the retina. It's often a multi-step process to save vision in severe congenital glaucoma. We also need to remember secondary glaucoma causes in kids chronic steroid use. Trauma, post-cataract surgery inflammation, and chronic uveitis are major culprits.
All right, Section 6. Let's talk about trauma. It's highlighted as a massive and often preventable cause of childhood blindness. Chemicals seem to pose a unique and devastating threat.
Yes, chemical burns to the eye are particularly terrifying in children, especially those caused by strong alkaline substances, things like drain cleaners, oven cleaners, cement mix, or even some traditional substances like edible tuna, lime wash.
Why are alkalis worse than acid?
Alkalis rapidly penetrate deep into the ocular tissues, the cornea, conjunctiva, even into the anterior chamber through a process called saponification, essentially turning the tissue into soap. This causes ongoing progressive damage long after the initial contact. Acids tend to cause more superficial coagulation, which can sometimes limit deeper penetration.
So prevention is key.
Absolutely. Education aimed at parents, caregivers, and the community about the dangers of certain toys, like projectile toys, bows and arrows, sharp-pointed objects, unsupervised access to household chemicals, and the risks associated with things like fireworks is essential.
What is the absolute most critical, immediate first step someone should take if a chemical splash occurs in a child's eye?
Immediate and copious irrigation. Don't hesitate. The eyes must be thoroughly washed out immediately with any available clean, drinkable water or saline solution.
For how long?
For at least 15 to 20 minutes, continuously. You need to physically pry the eyelids open if necessary and flush aggressively to dilute and remove as much chemical as possible before transporting the child. Then rush them to the nearest hospital or eye care facility.
In the source notes, they should be kept fasting.
Yes, the child should ideally be kept fasting, receiving only IV fluids if needed during transport. This is crucial in case urgent examination or surgical intervention under general anesthesia is required upon arrival at the hospital.
Now, you noted earlier the rare but incredibly severe risk of sympathetic ophthalmitis following a penetrating eye injury. Can you explain this devastating inflammatory disaster again?
Sympathetic ophthalmitis is one of the most feared complications after a severe penetrating ocular injury, although thankfully it's quite rare now with modern surgical techniques. It's a bilateral, diffuse granulomatous pannivatus, meaning severe inflammation affecting both eyes.
Even the uninjured eye?
Yes, the inflammation occurs in the normal, uninjured fellow eye, sometimes weeks, months, or even years after the initial severe injury to the first eye.
What's the mechanism?
It's believed to be an autoimmune reaction. The initial trauma exposes previously sequestered uveal antigens, proteins from the iris, ciliary body, or choroid, from the injured eye to the body's systemic immune system. The immune system becomes sensitized to these antigens and later launches an inflammatory attack against the similar tissues in the healthy fellow eye.
How do you minimize the risk?
Meticulous primary surgical repair of the initial penetrating injury, removing any prolapsed uveal tissue, is thought to be the most critical factor in minimizing the risk. In very rare cases of a completely blind, severely traumatized eye with no visual potential, a nucleation, removal of the eye, might be considered within about 2 weeks of the injury to prevent sensitization, but this is a decision made with extreme caution. #tag retinal diseases.
Let's move to the retina. What are the unique challenges regarding retinal detachment, Artie, when it occurs in children?
Retinal detachment in children can be caused by trauma, or it can occur spontaneously, often linked to conditions like high myopia, previous eye surgery, or specific genetic syndromes like Stickler syndrome.
What's the main challenge?
The unique and most significant challenge is often the delayed diagnosis. Adults typically report the classic symptoms of RD quite clearly: sudden onset of floaters, flashing lights, photopsia, or a curtain or shadow coming across their vision.
But kids don't.
Children, especially young ones, rarely report these relatively subtle symptoms. They might not understand them or be able to articulate them. This means RD is often diagnosed much later in children, frequently only when the detachment has progressed to involve the central macula, severely compromising the functional prognosis even after successful surgical reattachment. Time is retina.
And what about the inherited retinal degenerations mentioned?
These are a group of genetic conditions that cause progressive dysfunction and death of retinal cells, usually photoreceptors or the retinal pigment epithelium. Retinitis pigmentosa, RP, is a major group within this category.
How does RP present?
RP typically causes gradual, painless, bilateral vision loss. Often, the first symptom is nyctalomia, night blindness, followed by a progressive constriction of the peripheral visual field, leading to tunnel vision. Central vision is often spared until late stages.
Any others?
Macular dystrophies, like Stargardt disease, primarily affect the central macula, causing loss of central visual acuity and often color vision problems, usually starting in childhood or adolescence. While currently, there's no specific cure for most of these inherited conditions.
What's the management?
Management focuses on accurate diagnosis, including genetic testing, providing genetic counseling to the family, prescribing low vision aids and rehabilitation services, and monitoring for potential complications like cataracts or macular edema. Research into gene therapy and other treatments is very active, though.
We also have vascular issues mentioned.
Yes, things like Coats disease, which is an idiopathic condition causing abnormal retinal blood vessel development and leakage. Exudative retinopathy, often presenting with leukocoria or strabismus. Retinal hemangiomas or arteriovenous malformations can also occur, sometimes associated with systemic syndromes. Diabetic or hypertensive retinopathy are generally only seen if the underlying systemic disorder is very severe and long-standing in a child. Hashtag retinopathy of prematurity, ROP.
Okay, we must revisit ROP, retinopathy of prematurity, in this section as it connects right back to our discussion of high-risk infants and screening. Remind us of the basic mechanism.
Right. ROP is fundamentally a problem of abnormal retinal vascular development in response to the premature transition from the relatively hypoxic intrauterine environment to the relatively hyperoxic postnatal world, especially if supplemental oxygen is needed.
So the vessels react poorly.
In essence, the underdeveloped retinal blood vessels at the periphery stop growing normally. The peripheral retina then becomes hypoxic, lacks oxygen, and starts producing massive amounts of vascular endothelial growth factor, VEGF, as a signal to try and force new blood vessel growth.
But the new growth is bad.
This leads to chaotic, abnormal new vessel growth, neovascularization, often growing forward into the vitreous instead of staying flat within the retina. These abnormal vessels are fragile, they leak, they bleed, and most dangerously, they cause fibrous scar tissue to form. This scar tissue then contracts,
Pulling the retina off.
pulling on the retina, leading to tractional retinal detachment and potential blindness.
So what is the specific goal of the ablative laser treatment used for severe ROP?
So, children identified as high risk, born typically before 32 weeks gestation or weighing less than 1,500 grams, undergo mandatory periodic retinal screening exams starting a few weeks after birth. The goal is to detect when the ROP reaches a specific stage of severity known as threshold disease, or nowadays often type 1 ROP based on ETROP criteria.
And that's when you tweet.
Yes. This is the point where the risk of progression to retinal detachment is high enough to warrant intervention. The standard treatment is ablative laser photocoagulation.
What does the laser do?
The laser is used to intentionally destroy the peripheral avascular non-perfused retina, the area that is producing all the excess VEGF. By eliminating this hypoxic tissue, we dramatically reduce the source of the VEGF production.
Turning off the signal.
Exactly. We turn off the signal that's driving the dangerous neovascular growth, allowing the existing abnormal vessels to regress, thus preventing the progression to tractional retinal detachment and blindness in most cases. Anti-VEGF injections are also used now in some cases, but laser remains a mainstay. Hashtag blindness and low vision.
Let's close the clinical discussion now by putting visual disability into the World Health Organization's WHO global classification context. How does the WHO categorize different levels of vision loss?
The WHO classification system is important for standardizing definitions for public health and epidemiological purposes. It categorizes visual disability based primarily on the visual acuity, using a Snellen chart equivalent, and sometimes the extent of the visual field, usually assessed in the better seeing eye with the best possible correction.
Can you give us the main categories?
Sure. Category 0 is normal vision. Category 1 involves some vision loss, but is still considered near normal or mild. Category 2 is often used to define moderate visual impairment, or sometimes functionally as a one-eyed person, e.g. good acuity, 66 to 618 in the better eye, but significantly worse, maybe less than 660 in the other.
Okay, and then low vision and blindness.
Categories 3, subdivided into A, B, C, D, E, generally represent increasing levels of severity that fall under the definition of low vision. This typically ranges from visual acuity worse than 618 down to about 360. Then, categories phi, A and B, define blindness, which is generally considered visual acuity of less than 360, or counting fingers at 3 meters, in the better eye, or a severely constricted visual field, often less than 10 or 20 degrees around central fixation, regardless of acuity. Category V is total blindness, no light perception.
And this standardized classification directly supports that global initiative, Vision 2020. the right to sight.
Exactly. This global effort, launched by WHO and the International Agency for the Prevention of Blindness, IAPB, aimed to prioritize the elimination of avoidable blindness worldwide. It specifically targeted conditions with a high preventable or treatable burden, such as cataract, especially in adults, trachoma, an infectious cause of blindness, childhood blindness, which includes tackling ROP, congenital cataract, vitamin A deficiency, and measles, and addressing uncorrected refractive errors and low vision through accessible screening and affordable spectacles. The entire field of pediatric ophthalmology really operates within this critical mandate, recognizing that the vast majority of blindness in children is preventable or treatable, but only if caught early within that vital developmental window. #outro. So we have really executed a complete high-level sweep of this incredibly important and time-sensitive field. I think the key insights for achieving mastery here are embedded in recognizing those subtle, often nonverbal cues, understanding the profound systemic connections, whether it's the bothamos of glaucoma signaling a drainage issue, the leukochorea of retinoblastoma demanding urgent cancer referral, or the melting cornea of keratomalacia screaming systemic failure. And above all, internalizing the absolute imperative that functional vision for a lifetime is so often dictated by stringent adherence to that critical first 6-year treatment window for amblyopia. The child's eye truly is the nexus of their systemic health, their future neural development, and their interaction with the world.
So what does this all mean for you, our informed listener, trying to master this? It means understanding that pediatric ophthalmology requires not just precise diagnostic and surgical skill, but perhaps even more importantly, the clinical acumen to connect subtle signs in a nonverbal patient to potentially complex systemic and genetic pathologies, all while that developmental clock is ticking relentlessly.
Well said.
Okay, here's a final thought to leave you with. We discussed in detail that implanting an intraocular lens is generally avoided in infants under 2, primarily because of the rapid, somewhat unpredictable growth rate of the eyeball during that period, which messes up the power calculation.
Right. The axial length changes dramatically.
So if the eye is growing that fast in the first 2 years, fundamentally altering the optics needed for an IOL, what practical and ongoing clinical challenges does that same explosive growth rate pose for the accurate, long-term prescription and management of just regular spectacles or contact lenses as the child continues to mature through preschool and early school years? How often do those prescriptions need checking and changing to keep pace? Something to perhaps mull over as you continue your deep dive into applied clinical knowledge in this field.